Hello and welcome to this guidelines Pulmonary Embolism 2026, which is released by AHA. We will see why these guidelines and what are the major changes and how we are going to apply it bedside in clinical practice. So if we see the global burden of venous thromboembolism and pulmonary embolism is a spectrum, and in India the incidence is reported as 1.79 per thousand population, or 53 to 162 per 1 lakh population in the DVT range. The National Task Force of VTE has already suggested the need of pulmonary embolism response team in India. And on the right side, if we see the spectrum of the disease, and if we see there is a steady decline in the mortality, which is released by this Lancet journal from 2001 to 2023, and this is because of the better diagnostic and better workup, and we have to overall increase the awareness of uh, suspicion of clinical pulmonary embolism in patients like in heart attack and stroke. There is decreased awareness regarding the pulmonary embolism. So let's see what are the new highlights and what are the changes. So I will just give the summary. The first thing they have changed is the clinical categories from A to E according to the severity, starting from asymptomatic, symptomatic to severe state. They have also given greater emphasis on the respiratory failure status and added an R component which can be applied bedside clinically. We can have a clear guideline for those patients who are low risk and asymptomatic can be discharged home so that there is no burden on the hospital. There is a strong preference for direct oral anticoagulant over the vitamin K antagonist, which we know has a lot of interactions. Then about the RV imaging, now the echo is becoming the part of clinical practice, and every intensivist should have training for echo. And the RV imaging report formalization has been given in these guidelines. As in trauma, as in stroke, there is a teamwork. Similarly, pulmonary embolism response team recommendation has been given, where the vascular surgeon, the cardiologist, the intensivist, patient relatives, the pharmacist, and the availability of drug, whole hospital should be geared up, and there should be a defined team in severe cases. Now about risk stratification, which were given in the previous guideline, remain the same, but they have been reinforced, like pre-test probability. So this D-dimer use, it has to be age specific D-dimer. That is, suppose somebody is 60 years, so the threshold will not be 500, but it will be 16 to 10. That is, age into 10 is 600 is the threshold. Smarter use of D-dimer means it should be used as a negative predictive value, because we know that D-dimer can be raised in so many other conditions. CT pulmonary angiography remains the first gold standard for diagnosis of pulmonary embolism. The use of low molecular weight heparin, which doesn't require monitoring with doses, we know is preferred over the unfractioned heparin, except in certain cases. And the anticoagulation, extended anticoagulation when appropriate, if the risk factor persists, has to be continued. Now, how these guidelines have been made is depending on the class of recommendation. You see that class 1, 2, 3, like here. So if class 1, it is a strong recommendations, and level A means they are based on the 2 randomized controlled trial. The level B means they are one randomized controlled trial. Level B NR means non-randomized trial, and level C EO means the expert opinions. These are all the guidelines are in the similar format, where they are evidence based depending on the results of multiple randomized controlled trial. They are marked as strong, moderate, weak, or some class 3 as harm recommendation. So we have to see the guidelines in that perspective. So what were the earlier guideline 2011? If we see the AHA recommendation, they have stratified the pulmonary embolism as low risk, massive, and submassive. The problem with this terminology was what looks massive to me can be submassive for some other clinicians. Though they define the systolic blood pressure less than 90 for more than 15 minutes as a massive pulmonary embolism, but there still was the ambiguity. So that's why it was later on in 2019, the European consensus came with the modification in categorization to low risk, intermediate low and intermediate high risk, and then the high risk category where there is clear cut hemodynamic instability. Now this intermediate low risk and high risk were based on the PESI score, that is pulmonary embolism severity index, and also on the right ventricular imaging and the troponin levels, the biomarkers. What is new in these guidelines is they have further classified so that we can apply it to the bedside, and they have classified as A, B, C, D, E category, which is a simple category where D, C, D, E are the severe category symptomatic with or without respiratory component, where they have marked as separate R component, and A and B are asymptomatic. B is suppose a patient with CA comes to the for evaluation, you find subsegmental PE comes in low risk. So this A and B are the categories for the OPD management, where the clinician can take a decision regarding early discharge on OPD management. So this is the best classification which they have given in 2026. We need to go in further details of it. So these are the categories I was describing about. So A and B, A is subclinical or incidental P, and B is the symptomatic but low risk and subsegmental or non-segmental. And these are the can be treated as outpatients. So A and B you can classically evaluate and treat as an outpatient, and you can consider the early discharge. Now the other category which we need to understand, which we day to day basis we manage in the ICU, is from the C, D and E. So how they have further classified it is these are the symptomatic one, and they may have plus minus, they have added the respiratory component. So need of oxygen, need of ventilation in severe cases, or a need of non-rebreathing mask, or respiratory rate is high. So depending on that, you have to add the R component to the, and this patient needs to be monitored in the intensive care unit. Now see, if you see category, if you further evaluate, this is integration of clinical, radiological and the biomarkers together. So if you see the patient has clinical symptoms, C category, and if he has the normal RV and biomarkers, he may be categorized as C1. And if the patient has abnormal RV or abnormal biomarker like troponin or BNP, so he may be marked as C2. And if both are abnormal, RV imaging findings and the abnormal biomarker, it is severe category C3. D and E are depending on the hemodynamic component. So D1 is the transient hypotension, and D2 is the normotensive shock, where the patient's blood pressure may be normal but there is a sign of organ hypoperfusion. Now E is the severe most category, where there is a persistent hypotension with cardiogenic shock and refractory cardiogenic shock. So these are the categories which require the multidisciplinary team and pulmonary embolism response team. So this is the major change in this 2026 guidelines. Now if we see pulmonary embolism rule out score, so these are the scores which can be used at the triage level at the ER, and if any of this is negative, like age is less than 50, heart rate less than 100, oxygen, simple parameters which can be monitored by a paramedic also, and he can label this patient to rule out pulmonary embolism. So if the answer is yes here, if there is history of insulin unilateral swelling, so this patient needs to be further evaluated. Similarly, PESI index, this can be marked if the most important category, if there is a heart rate more than 100, the blood pressure is less than 100, and respiratory rate more than 30. So these are the TPRBP. This is normal TPRBP and oxygen saturation, which we monitor in the ER. And if there is a suspicion of pulmonary embolism, this is the PESI index. If it is high, the patient needs to be monitored. If it is low, then if fall in A or B category, may be considered for OPD discharge. So HISTIA criteria, another criteria which is for the admission criteria or the OPD decision. This can be also a tick mark where the hemodynamic instability, creatinine clearance, severity of illness, documented history of heparin-induced thrombocyte, hemodynamic instability. These are the criteria which are freely available and can be marked for admission or discharge. So these criteria are used for the triaging. Now, most important in ICU, we use the risk modified well score. The most important thing is the clinician. So, if I suspect patient is bedridden, there is a symptom of DVT, or there is no alternative diagnosis in the mind of clinician, straight away your score becomes more than 4, and this patient has P likely need to be worked up. So, this well score is very well used in the bedside. And the counterpart Geneva score, similarly, if the patient has pain or unilateral limb edema, when you are examining the patient, the heart rate is more than 95 and you have a suspicion of pulmonary embolism, so straight away your score again becomes more than 4 and it has to be evaluated. So revise Geneva score, and the most important being, as I told, the pain in the limb, limb, examine the heart rate, and if there is a suspicion or previous DVT, and this becomes the important risk factor, and you need to evaluate. So categorization is important. Let's now apply it bedside. So we understood the category from A to A, E, and how to apply in bedside. So this is a patient with acute PE with breast cancer, sudden dyspnea, tachycardia, hypoxemia with bilateral lobe pulmonary embolism, but no RV enlargement or troponin elevation. So what will be category of this patient? Take a moment to understand this. Now this patient has a respiratory symptom, so R component is there. Patient is symptomatic, he falls in the C category. Patient is hemodynamically stable. Patient has a bilateral lobe, the RV and troponin elevation. So there is no RV enlargement, troponin elevation. So he becomes a category of C1R. Next patient, post-operative patient, pleuritic pain after hip replacement and SPC has been found to have a segmental right lower lobe PE without RV enlargement on CT. So this patient is low severity index, and he is having without RV enlargement segmental P, against becomes a category B because he has symptoms but low severity index, can be managed in OPD basis. Patient C3, he is underwent spine surgery, sudden onset dyspnea, tachycardia, hypoxia, has normal systolic blood pressure, found to have P in right and main pulmonary arteries, and increase in creatinine and low mean arterial pressure. So he has a hemodynamic instability. So he belongs to the severe most category, and the respiratory component is there. So the categories become C1R for first patient, B2 for second patient, and D2R for third patient, where there is normotensive shock. So D2R. Let's move ahead with another case here. A 54-year-old post-operative internal fixation of traumatic fracture of neck femur, and patient is shifted to ICU. He has tachycardia, tachypnea, saturation 2 liters of oxygen required, RR is 28. So first thing what we from this guideline we can apply bedside is what category my patient falls. So patient is having respiratory distress. We have a high index of clinical suspicion. Well score is high, so we do consider this patient ICU admission, and he belongs to the C category. CR component is there. We further evaluate with the ECG. Troponin is raised, D dimer is raised as per age, so the biomarker is high, and that's why this patient belongs to the C2 category. We don't have an echo report yet. So what is the diagnostic imaging decision? So in this patient where we have high well score, where is post-operative patient where the D dimer is high, the CTPA, CT pulmonary angiography is the gold standard for managing for diagnosis of pulmonary embolism. The other choice is VQ scan, the bedside echo, MRA are not recommended in the current guideline for this kind of patient. They have select patient for this kind of thing. And should I do the duplex venous Doppler? So according, once we diagnose the PE, we want to prevent the recurrence, we want to go for the venous Doppler. What does the new guidelines say about this? So these are the guidelines. If you see, there are strong recommendation, and if you reach each one of them, they strongly recommend CTPA over VQ scan for diagnosing pulmonary embolism. In special situation, you can use single photon emission computerized tomography if the patient has a risk of contrast allergy, or if there is a increase in the creatinine. In such cases, select cases, you can consider 2A category, but the gold standard is CT pulmonary angiography. In pregnancy also, with the reasonable low dose perfusion scintigraphy, they have recommended. These are freely available, you can go on the site. So major RV imaging. Why RV imaging? Because we know that the pulmonary embolism, there is right-sided obstruction, and all the pathophysiology and right ventricular dysfunction occurs because of the increase in RV dilatation. These are the physiological changes which happen where there is increase in RV demand, decrease RV contractility, decrease RV output, decrease in the mean arterial pressure, and ultimately cardiogenic shock and death. So these are the right-sided ventricular dysfunction, and this picture depicts the how it happens. So risk stratification, they have mentioned clear-cut 2D echocardiography to not only mention RA-RV dilatation, but they have given the values where it has to be methodical, and reporting findings should be in this systematic pattern where you should report the end diastolic diameter as more than 42, and various views like subcostal, apical, four chamber, and ability to measure the tricuspid annular plane systolic excursion, and it should be less than 1.8 centimeter is abnormal. So they have given the values with which you have to report the RV assessment to make it more standardized way of reporting for pulmonary embolism. So well, coming back to our patient, the well score is 6. Echo shows the RV and LV ratio more than 1.5, and CTPA is done on the right. You can see the filling defect, and there is the evidence of pulmonary embolism there. What should be the plan? Now this is a post-operative patient, underwent spine surgery. He has been diagnosed in CTPA as pulmonary embolism, and what modality of treatment as per the new guidelines. So the clinical category, he is hemodynamically stable, so it is C3R. So the anticoagulation is the most practical option as bleeding risk in view of postoperative patient, or we should give half dose thrombolysis, or we should go for catheter directed mechanical thrombectomy or surgical embolectomy. So in this particular patient, there is no hemodynamic instability. You should have a discussion per team, and this patient has to undergo the anticoagulation, which is the safest with the low molecular weight heparin. There is no role of thrombolysis in this patient. Now, if we see the initial anticoagulation, we can use all these agents: unfractioned heparin, enoxaparin, fondaparinux, or rivaroxaban, which is a oral anticoagulant. The doses are given here. The point to remember is that this new direct oral anticoagulants, which you will be prescribing at time of discharge, may have a renal excretion, most of them, and you should adjust the doses if the patient has a AK or CKD issue. So in management guidelines also, if you see from C to D category, initiate low molecular weight heparin is the first line treatment, then assessment cardiac marker, see the lactate as a measure of perfusion, evaluation of CT and RV imaging we have already done, and validation of scores. So these are the categories and the treatment. And in severe most category, only there is a role of thrombolysis, or in life support like VA ECMO if there is a refractory shock in category E. So if we see thrombolysis, these are the various agents. Nowadays we have a fibrin specific tenecteplase as per the weight you can use, or RT-PACE 100 milligram over 2 hours. That is the standard dose for thrombolysis in patient with hemodynamic instability where there is no contraindication. You should look for contraindications like if the patient has recent surgery, recent trauma, neurosurgical lesion, or you have to control the blood pressure. As you thrombolize any other case, you should manage the blood pressure and presentation, which may be relative contraindications like advanced age and CPR, pregnancy. So these may be the relative contraindications. So you should decide with the expert in such patients. Therapeutic option for C to E category, as per the guideline, if we see, they have also recommended multidisciplinary pulmonary embolism response team for management. The decision regarding the systemic thrombolysis is 2B criteria and systemic thrombolysis catheter directed treatment or the mechanical thrombectomy or systemic thrombolysis if acceptable bleeding risk, that is 2A category. So if we see, these are for the E category where the patient is hemodynamically unstable. This is the PERT team. If integration, you see the vascular team, you see the pulmonary critical care, cardiac surgery team, pulmonary, nursing, pharmacy, and intensivist. They all form the PERT team, and the responsibility is for improved risk stratification, better outcome, and selection of appropriate therapy for that patient, evidence-based, and this is what we should aim for at our local level to form such team and prevent the mortality in such patients. Now coming to critical decisions which has to be taken. So patient with viral pneumonia on mechanical ventilation diagnosed with saddle pulmonary embolism, severe hypokinesia on echocardiogram, all the findings, and hypotension despite 3 vasopressors. So this patient, category E, definitely goes for thrombolysis. If you have any contraindication systemic thrombolysis, you have to go for catheter directed or mechanical thrombectomy, or if the patient is grossly hemodynamically stable, patient may require a mechanical support in form of VA ECMO. So these new guidelines are very practically integrated and can be applied bedside. So PERT response team is important recommendations which AH has made to improve the patient outcome. So this is the wheel of success, what I say for the acute pulmonary embolism. So if the category A to B, you go for direct oral anticoagulant OPD based treatment. If the patient belongs to C1 to E2 and stable, you have to go for LMWH or unfractioned heparin or systemic thrombolysis or catheter direct therapy or mechanical thrombectomy, special category like E2 where there is severe hypotension and hemodynamic instability. So there is the treatment. So these are the very clear defined guidelines which are there. So our patient also shows the venous Doppler shows the DVT in the right iliac venous region. So if there is an increased thrombal load and prevent the recurrence and there is a floating thrombus, you have to select the cases and decide about and if the patient is going to be bedridden, then the role of mechanical device like IVC filter. Now as far as inferior vacuum filter is considered, it is recommended only for patient who cannot tolerate anticoagulation or the risk of thrombosis is very high as a patient bedridden. The routine IVC filter placement should not be recommended who are therapeutically anticoagulated, and it should be retrievable. Once the risk factor goes, the filter has to come out. So given the complication, the new guidelines clearly mentions about this IVC filter recommendation. Now coming to duration of anticoagulation is important where if the risk factor is identified and 3 months are enough, the clinician has to judge the risk versus bleeding risk versus thrombotic risk. If there is a cancer or underlying malignancy, he may have to take more duration, has to be extended duration like 6 months, 18 months or more depending upon the patient assessment. So you have to, the drug of choice recommended is direct oral anticoagulant therapy, which is recommended over vitamin K antagonist in the new guideline because they have less interaction and better compliance. Like in tuberculosis patient, they are very well with the taking compliance of the therapy we check. Similarly here the PE clinic follow up this patient, and the first week you have to see the compliance, whether he is taking his anticoagulant properly, because patient may be asymptomatic and he may miss the medication, and that will be the increased risk. So first week follow-up should be checking the compliance, adherence, and also we have to reinforce the risk of thrombosis and patient we see that he takes the medicine properly. At 3 months, we have to call him and start looking for PTSD, post-traumatic stress disorder. We have to give the family support and psychological well-being of the patient. Also, we should be worried about the chronic thrombopulmonary embolic disorders, walk test, which we used to do in the COVID time. So CTPED screening has to be done, and this may be the cause of persistent dyspnea in this patient, and it has to be screened. So if we see in summary, these new guidelines are very clearly gives the pathway. We have history, physical examination, high risk stratification. We belong to patient has to be admitted CDE. If is asymptomatic or subclinical, he has to go for the OPD basis. And this is a pathway where we have to assess to the PERT team, and according to the severity, the treatment which we have discussed. So very clear, simple bedside application. There are special situations where the decision for DOAC may be deferred, like in pregnancy, it is causes more harm than good. So in such patients, low molecular weight heparin in pregnancy is preferred over the DOAC or vitamin K. In severe liver disease or kidney disease, the clinician has to take a call. There is no clear confirmed, uncertain whether the guidelines are uncertain regarding use of apixaban in this patients of severe chronic disease or chronic liver disease. So that is how these guidelines go about. So in summary, the take home is this new clinical classification is integration of clinical markers, and we have to categorize the patient bedside as per the severity system, whether he belongs to A to E category, and accordingly we have to start the treatment. The direct oral anticoagulant is most favorable compared to low molecular heparin. The advanced therapies like systemic thrombolysis, catheter directed, and mechanical thrombectomy, surgical embolectomy is recommended for category E1 and may be considered for D1 to D depending on the patient's presentation. Pulmonary embolism response team are recommended to improve care and delivery outcome. Decision regarding the duration of therapy depends upon the persistence of this factor. May have to go for extended duration anticoagulation, and follow-up has to be very strict for compliance, and also for screening for CTPED, chronic thrombopulmonary disorder, at least for 1 year. Thank you for your patient listening.